Dr. Dan from Empower Fertility. Love him.
He's great. He actually had to bring somebody from his staff to keep him on track and to stop him rambling on and talking too much and taking over everything. And she was partially successful.
Yeah, I actually think I talked too much and took over everything. But anyway.
I wasn't going to say that.
It's a great episode. I love him. I love your dynamic with him and the way you guys work together and support each other.
Yeah, it's great. I enjoyed it a lot.
It's a great episode. Enjoy.
But what do I know? I'm just a vagina doctor. Dr. Daniel Rychlik, welcome to the Vagina Doctor podcast.
Well, thank you for having me. It's really great to be here.
So I'm going to just read your intro bio because it's a little easier that way. Dr. Daniel Rychlik is a globally renowned fertility specialist, boasting over a decade of expertise, holding dual board certifications and reproductive endocrinology and obstetrics and gynecology. Dr. Rychlik has not only founded but also expanded numerous infertility clinics across the nation, actively guiding fellow specialists, imparting knowledge at various educational institutions. His academic journey encompasses degrees from the University of Illinois and the University of Chicago's Pritzker School of Medicine, with recognition as a CREST scholar. You must have written this yourself.
Yeah, it sounds great.
It really does. If I was going to announce you, it would be my surgical backup, somebody who takes call for me.
There you go.
Surgical assistant. But probably the true one is you're Dr. Drake's husband.
I am. I'm trying to officially change my name, but being Dr. Drake's husband gets everybody a little bit confused. But
okay. So, welcome. You wanted to talk particularly about miscarriages and infertility.
yes.
But wait, I just have to say one thing. I really want to be in the OR with you two sometime on one of your cases that you do together.
It's a fascinating time.
How do we make that happen?
Well, we can make it
Do
happen.
we sneak me in and put me in scrubs?
Well, as we're being recorded, we're not going to tell you that now. But we can make it happen.
Yeah, because I think you guys have so much fun.
Well, it's great. You know, the nice thing about Duncan, and I can call you by your first name, I hope. But,
Yes.
Yes.
Duncan is...
I prefer Dunk, actually.
Okay. Yeah. Is great to work with because he imparts knowledge that I think very few people have these days. And the real concern over the integrity of medicine. And that sounds kind of hokey, but it's really hard to find these days. And I come from a very academic background.
Mm-hmm.
And not that my job is really to take something that's an academic background and make it viable for people to understand. Not to put it on a pedestal so nobody can actually be a part of it, but really try to incorporate what you do with that. Because we are the gatekeepers of knowledge, and it's not to hold it inside and be the doctor that nobody wants to talk to. It's to really to impart that knowledge to other people. And that's the pleasure on it. And then I think Duncan comes from a very old world kind of understanding of that, where we do impart our knowledge to our patients and help empower them. And that's where the name of our company comes from, Empower Infertility, is the ability to give people information so that they can have the kind of information to make good decisions. So it's great to be here.
Great.
Yeah. Great to have you finally.
I know, my schedule's always busy.
I know. We just can't get you.
So infertility and miscarriage. What?
Yes. Infertility, infertility's got a bad word behind it. And so when we talk about it, we really have to get people to understand what it really means. When people want to get pregnant, they want to expand their families, want to have babies and such. And that word infertility's got a difficult connotation to it. Because for women and for men, having a family is a really important thing. It's actually how we exist as a species. And so if you look at that, what happens? You really need 3 things to get pregnant. Sounds very basic, but you need a dinner, music, great environment, and the right person. But no, what you really need is you need eggs, sperm, and a way for them to get to each other. I call it the club in which the egg and sperm meet. But what people don't understand is that infertility can be a natural process. The ability to not have a child is inherent to every couple. And unfortunately, and don't kill the messenger, I'm not the maker, but the maker made it so that women have the brunt of the burden of fertility.
Mm-hmm.
And infertility is a natural process for every woman. I could say that my mother, before she died, God bless her soul, was infertile. And that's not a pathologic condition. So it's something we deal naturally with. And most people don't understand that that natural process is something that we deal with every day. It's like saying you might get old and have cataracts and you might need your lens replaced. That wouldn't be something unusual. We wouldn't say, oh my God, you got a horrible disease. We'd just say, hey, time has made it such that you need intervention to help you through. And that's the same thing that happens with fertility. And as women become more prevalent in society and doing the things that can advance their careers, advance their desires, there's a prolonging of the ability to become pregnant. And that encompasses areas of fertility that naturally occur. And if you ask somebody, they understand that over time it becomes harder to get pregnant.
Yeah.
Ask a woman, well, why is that? And they'll say, well, I get older.
I'm getting older. I don't have as many eggs.
Exactly. And we say the O word, right? We don't use the word old. We use the word mature, where we say we get mature and that's what happens. And if we try to uncover that, what's really happening, and you say, well, I don't have as many eggs, and that's not really what's going on. What's really going on is that women, unlike men, are born with all the eggs they were going to have. And I like to think of eggs as like, I used to say Xerox copy machines, and somebody looked at me with like the eyes of, what is that? Because that just reflects my age. But I say, okay, photocopy machine. Everybody goes, oh, I know what you're talking about now. And I go, an egg is like a photocopy machine. And if you made them all when you were born and put them in a warehouse, and every month you dragged one out, you might say at the beginning, those photocopy machines work really, really well. But then after 20 years, 30 years, 40 years, you take one out, might not work that well. And the egg is the ultimate photocopy machine. It takes the sperm DNA, takes the egg's DNA, duplicates it, repeats it a bunch of times, and unfortunately, it has to get it right. Because everybody in the room, no matter what your opinion, is genetically normal. I can actually see that on you. I don't have to do any big testing. So most of the world has a set of genetically normal people. And how that occurs is that all that stuff has to work.
Mm-hmm.
And if you think about it, men make millions of sperm and women make 2 million eggs. And if you have one kid, you're really 1 in a million. Mm-hmm. And so what happens over time is the ability for that photocopy machine to actually get those photocopies to basically print correctly. And that creates genetic abnormalities. And those genetic abnormalities, instead of coming out to be people that we all hear and talk with and have babies with, they're lost. Mm-hmm. Because the body goes, I'm only going to allow good things to come out. And if it's got a mistake, I'm going to tell you to go back again and try again. And those mistakes happen more often as we get more mature. And so often people kind of, unfortunately, take miscarriage and infertility and don't understand that they're related to each other.
Yeah.
And they're related by that commonality of genetics. So if you look at somebody who's young, under 30, they got about a 10% chance of having a miscarriage. 1 out of 10 could have a miscarriage. And actually, as residents, if you look at most doctors, they'll quote that number because it's pretty common. We as residents go in the ER, somebody bleeds, has cramping, they're pregnant. We say you got a 10% of miscarrying. But if you take and move that to an older or more mature lady, mm-hmm. you're going to see that steadily rises. It rises actually really, really big to the point at 40, you're going to have 35 to 40% of those people miscarry. And so the inability to become pregnant is part having a genetically normal embryo that you can create, implant, and be successful at getting to term and delivering. And what will happen in between that is you'll get either infertility or miscarriage.
Mm-hmm.
So we have to kind of rethink the way we talk about this. Is it uncommon for somebody to have a miscarriage? No, I'm not saying that. I'm not saying, boy, you have a miscarriage, you have an infertility problem. But it might be you do.
Mm-hmm.
Now, who's more likely to have that? The 29-year-old lady or the 38-year-old lady?
Yeah.
And the 38-year-old lady, if she has miscarriages, that's a problem. Because when she gets pregnant, her photocopy machine's not working. And that's telling me that maybe she's not going to have time enough to find one. Because again, you're right. Over time, it becomes harder and harder to find it.
Yeah.
Because how long have you been doing this?
About 22 years.
22 years. So I did in vitro 21 years ago, had my daughter. The way things have changed since that time is incredible.
Yeah, it's really what I think, and I tell people is infertility started as a reactive science. And reactive in the way is we waited till you had a problem and then we intervened. And we weren't really successful in the beginning.
And I had to wait a while. I had to be a year with trying every month before I would get referred to an infertility doctor.
Exactly. And the reason for that is that people didn't know how to predict what your fertility was. So they had to wait until you failed before they intervened. We'd never tell anybody, I have high blood pressure in a doctor's office. And we'd never say, wait until you have a heart attack and then come and see me, and then I'll treat you. But we kind of did that for fertility. It's because we didn't have a good way of screening people who has a problem, who doesn't. And now infertility has gotten over being reactive to being what I like to call preventative.
Yeah.
And that comes in a myriad of different ways. Young women now can freeze their eggs, so they never have a fertility problem.
How, what is your opinion about that? Like, we all have daughters here.
Yeah.
So what would you tell them and at what age?
Well, my family's a little bit unique in that there's an OBGYN in the house and an infertility doctor. So our kids, we have 4 kids, 3 girls, 1 boy, and our kids know very early on what goes on because they can see it all around. They hear about it all around. When would I tell them? One of the things that's interesting is like my oldest daughter is becoming an Air Force pilot. And before she did all that, she froze her eggs.
And wait, how old is your oldest daughter?
24.
Okay.
And she froze her eggs and she said, listen, I don't want to worry about it later on. I want to have my career. And she froze her eggs and now she can have a baby anytime she wants.
Yeah.
Kind of incredible, right?
Yeah.
The other part is when is a good time? Everybody's saying when is a good time to do that? Well, you almost think when things are really good, that's the time to put money in the bank or eggs in the bank. When you're more mature, it may not be a good time. There's never a bad time. If you ask somebody about a savings account, when is a bad time to put money in your savings account? When times are ripe and when times are bad. And you can say, well, it's always good to put money in a savings account because you can have it for a rainy day. But if you ask me, especially in the days that we have where women's rights are so important and so much being challenged, the ability for a woman to have eggs frozen allows her to make a couple of things. Career decisions.
Yeah, exactly.
Freedom. The ability to say, hey, I don't have to be on your timeline to make this work because I know it's eventually going to go away and now I can secure it for the future. That's an incredible thing. If you think anything about women's rights, control of your fertility, that's really what we're talking about in a lot of these things in what's going on, is control of your fertility is very important. And freezing eggs is one of the ultimate controls you can give any type of female. But, the infertility is going to happen to everybody. I always tell people, what are the biggest growing populations of infertility in the world? There's two that are huge. And they're China and India. And they have the greatest growing population of infertility. And you go, well, what's going on? And I say, well, with any growth of any industrial society, you get a rise in the middle class. What does the middle class do? It does things that they didn't do when they didn't have that. And they basically get the ability to advance their careers and stuff, and they delay fertility. Mm-hmm. And by delaying it, they have infertility.
Right.
So there's more infertility going on in China and India than anywhere else in the world. I used to work in China and do infertility. We would do 20,000 cycles a year.
Oh my God.
In India, this is one clinic. In one clinic, we would do in India 15,000 cycles a year. In about a month, I did transfers and got 123 women pregnant in 1 month. So it's just exploding in those areas. It's not that they've uncovered or had more fertility because of something that's going on in their environment and such. They've just waited to a point where the natural process is starting to shine through.
So it's different than like girls here doing what you just described as the preventative, taking their fertility into their own hands, freezing their eggs, or let's just say they've decided they want to be pregnant and they just want to get to it right away,
right?
And not try and then see. But
exactly, you can say, I find almost every age group is starting to freeze their eggs. So young women and more mature women. The difference is that, and let me give you some numbers so it makes it real. If you have a 30-year-old, they secrete an egg every month during their ovulation. About half of them are genetically normal. Mm-hmm. Half. That sounds pretty bad, right? So that means they're going to secrete 6 good eggs a year. You go to 35, and you're only going to have 33% of them normal. Means you're only going to secrete 4 good eggs a year. Take that to 40, you're going to secrete 1 good egg a year.
Wow.
Take it to 44, you're going to secrete 1 good egg every 4 to 5 years. Does it mean you can't get pregnant all those times? No, it just means it's more challenging. So I often get, and you probably know this, you get somebody that says, oh, I know somebody that's, gotten pregnant at 45.
Yeah.
And I know this. And I go, you know what? I used to be in Chicago. I know Michael Jordan, but I can't play basketball like he does. So just knowing somebody doesn't make it true for you. And you're probably talking about the outliers more than the common person.
Yeah.
Absolutely. Yeah.
So, so that part of miscarriage is something I like to tell people, when they have miscarriage, it's a horrible experience. They're trying to get pregnant. They do all the work. I often hear people go, oh, I got close. Mm-hmm. Or I don't have a fertility problem because I got pregnant. Mm-hmm. And I go, really, a fertility problem is about having a baby. It's not about getting pregnant.
Yeah.
So miscarriages can be somewhat of a heralding of an infertility problem and something we want people to look into. And I think there's this thought, if you see a fertility doctor, you're going to get a fertility treatment. But really, like any other part of medicine, we're here to educate. And sometimes they say, hey, looks okay. You're going to be fine. I reassure them. And that gives them that degree of security. Because what happens, you are trying to get pregnant. You go off. You don't get pregnant. Every holiday, somebody comes to you and says, are you pregnant yet?
Yeah.
Maybe you should just relax.
Yeah.
Why don't you take a vacation?
Have a margarita.
Have a margarita. I'll do it. It did it for me.
Yeah.
And you go, yeah, but you were 20 years old and I'm 36.
Right.
So we try to give people information so they can either be reassured or tell them before it happens. I'll give you a great story. I was doing some advanced scuba training, and my instructor was talking to me, and as we were going through, she asked, "What do you do for a living?" I says, "Well, I'm a fertility doctor." And she said, "Oh, man, I've been trying to get pregnant. And about 6 months ago, I had a miscarriage." And I went, "Oh my God." I wanted to say, "Please see me."
Mm-hmm.
But I didn't want to do that in that. I mean, it's uncomfortable. So my wife was also doing scuba lessons, and she heard it, and she said to her, "You need to see my husband now."
Yeah.
And she goes, no, I don't have a problem. And she ended up eventually seeing me. And we just signed her off with her pregnancy. And she goes, and she realized it after everything that happened. It was not an easy road, but we got her there rather efficiently. But she says, if I didn't see you in that lesson, I probably wouldn't have had a baby.
Mm-hmm.
And I said, "You're right."
Wow.
Pretty cool. Cool.
It's so cool. And I mean, and just going back to the time of like 20 years ago to now, and how it has become more of a science in some ways than.
Yeah, I think it was.
The things happening in the process of.
Yeah, it's like with anything in medicine, you understand more the more information you get.
Yeah.
First, you're trying to react to a problem. And then you start saying, when people would get sick, that's when doctors intervened. Now what do? We intervene before you get sick to prolong your life. If you ask anybody, why are we surviving longer? It's really because of modern medicine.
Mm-hmm.
Nobody's surviving because all of a sudden, they did anything that was unusual. If you think of the most natural people, those are the people that have been out in a tundra for millions of years.
Mm-hmm.
But we're able to give medication, change lifestyles, intervene.
Definitely intervene. And like when we called you the other day about my niece and the PCOS.
Yep.
I love how you and Duncan took it on, and it was really fascinating to you and reaching out to somebody else.
Yes.
And can we talk about PCOS for a moment?
Yes. I love PCOS. So I come from the University of Chicago, which, if nobody knows, that's where PCOS was discovered.
Ooh.
And so that's pretty much the Stein-Leventhal syndrome. And Stein-Leventhal were professors at University of Chicago, and they noticed and they observed something that was unusual. And they categorized it early on. And if you ask me the year, I don't remember, but it was a long, long time ago. And
probably 100 years ago.
Yeah, it was way before they had any knowledge of what was going on. So all they saw was this pathological condition. And so they said, there's a problem. We don't know what to do with it, but we're identifying what it is. And, the thing is, if you identify something, you get your name put on it. And then we as medical students have to remember that name all the time, which doesn't help us very much except for on tests. But then to really understand it, and it's really taken leaps and bounds about understanding. And I can probably talk to you about PCOS for a week and not even scratch the surface about how things are actually happening. But if you understand it, it's kind of like this. PCOS is a syndrome of abundance. And I'll explain that a little bit. But the first thing to understand is PCOS is not in itself a disease. It's just a categorization of some symptoms. Duncan, if I was to tell you have a headache, it doesn't really tell you how you got that headache and what would the origin.
Sometimes they'd know.
But, you wouldn't, I'm sure you would, but you wouldn't know if it was from an aneurysm, it's a tension headache, it's stress, it's high blood. You don't know. It's just say you have a headache. And that's when people say PCOS, which is polycystic ovarian syndrome. People like to call it PCOS. Everybody gets a different name for it. What you're really saying is, I have this kind of symptomatology. I have a headache. That's what you're really saying. You're not really saying what the problem is. And what we know is that PCOS either is ovarian or metabolic, and they interact with each other. And the ovarian problem is that they actually, I'll give you the secret because that's the thing, is they actually have more eggs than they're supposed to. And when you have a lot of those eggs, they can spill over and have metabolic consequences. The opposite is actually true also. You can have metabolic consequences that make your ovary not work as well. Now, I've got to kind of explain that, so I'm going to give you some analogies.
Okay.
We're in a room here. It's a small room. And let's just say every month we want to ovulate an egg. The way the body works is it doesn't say, hey, you're the egg, you come over, you're going to ovulate this year. What the ovary says, there's a director in the ovary, I'll give it that, and he says, okay, I'm going to pick you 30 people, and you're all going to compete to see who wins. And it's actually picked about 280 days before the ovulation event happens. So it's a long time, which we could always get into how infertility works and all that. But you recruit a bunch of eggs. You say, hey, in 280 days, you're going to come to the thing. And what you guys are going to do is you're going to play like the Hunger Games. Okay? I'm going to throw a little bit of food in the middle and somebody's going to win. Or in this analogy, let's say, I'm going to bring you guys into a room and I'm going to say fire. And the first one that gets out the door is going to be the ovulated egg. And I'm going to shut the door and I'm going to kill everybody else inside. So you better be the one that gets out the door. You're not going to get there. We can talk about that, and that's what happens every month. When you're young, the amount that get recruited for that one to go out the door is about 20 to 30. When you're 35, it's about 15 people. And when you're 40, it's about 7. So there's 7 people in the room, 1 gets out, 6 get thrown away. PCOS is kind of like this. If I was to stuff this room with about 25 people and say, I want you to get out the door, nobody's going to get out. Mm-hmm. So you're not going to ovulate. You're going to get crushed in that door. Nobody's going to get out. That is the syndrome of excess. That's what PCOS is all about. So they actually have a lot of eggs. They just can't get out the door. Another analogy I like to give, because I like the feeding analogy, is I say, if you go to Starbucks and you have a coffee and you have a scone and you sit outside on a beautiful day and you want to have that, and there's a bunch of pigeons that come over. I'm from Chicago, so pigeons are abundant. And you threw a little bit of scone out there. One pigeon would eat it and fly away. That's the ovulated egg. And in my scenario, all the other pigeons would die. But let's just say you had so many pigeons there and you threw it down and they all kind of tore it apart and nobody was satisfied with getting fed and nobody flew away. That's PCOS. Now, what is the problem with menopause? The problem with menopause is, in that room analogy, there are very few people in the room. There's 2 people. And you say fire and they can't hear.
Interesting analogy. Okay.
In the bird analogy, you got 1 or 2 pigeons there and they can't see the food when it's thrown on the ground. Right. So nobody flies away. Mm-hmm. So PCOS is this syndrome of excess. And it's really kind of strange. If you think about it, fertility, we've known for a long time that it's inherited through people by a autosomal dominant type of pattern. That means that if you have the gene, you have the disorder. And so it's passed on through people. It can be passed on through the mother or the father. Now, if you look at the symptomatology of PCOS, what is it? It's usually some type of irregularity in your periods, although you don't have to have that. You can actually have normal periods. And you can have infertility. And one of the things that I used to say when I was doing research is, how can you have somebody that has an infertility problem pass it on with their genes? It just doesn't make any sense, right?
Right, it's weird.
So what PCOS is a syndrome. It's not one disease. It's a bunch of things. And the people that don't have the symptomatology of PCOS have one thing. They have excessive fertility. What do I mean by that? You have the people that get pregnant. They're pretty good at getting pregnant. Then you have these people that are really, really good at getting pregnant. I mean, they get pregnant like if the wind blows a certain way. And then it gets a little too much, and then they have PCOS. Mm-hmm. And people often say, well, Dr. Dan, you say these things. How do you prove it? And I say, well, when we treat with people with PCOS, we treat them and they're more likely to have multiple pregnancies, or what we call in our field hyperstim. That means they make an excessive amount of eggs. So when you start uncovering the thing that's preventing them from ovulating, you don't get them back to normal. You make them this hyperfertile state. And there's a bunch of people out there that have borderline PCOS that basically just get pregnant really efficiently. And the other way we see it is women who get pregnant on the pill.
Yeah.
That's another one that doctors go, oh, you know what? That can never happen. You just didn't take the pill right. Well, it turns out they're taking the pill right. It's just not ability to suppress the excess. Mm-hmm.
How do you treat the PCOS in patients? Like if they have it and they want to get pregnant, or do you treat the PCOS, or do you just do infertility?
So, it depends on the origin. And we talk about it being an ovarian problem and a metabolic problem.
Which is fascinating. I had no idea.
Yeah.
Until just recently that they were even connected.
Yeah. And it's like this. The worst PCOS patients, one might think, is purely metabolic. And oftentimes you'll see people that are overweight, they'll have PCOS. Those are actually the easiest ones to treat. Mm-hmm. They lose a little bit of weight, their PCOS goes away. The actually hard ones to treat are ladies that are thin, but have all of this excess in their ovaries. And oftentimes what we do, we have a problem getting them to ovulate. And let me give you an illustration. We had a lady one time, just very normal, 35-year-old, trying to get pregnant. And she just wouldn't ovulate. And we gave her some medication and it wouldn't work. And we would increase the dosage incrementally. And then instead of ovulating 1 or 2 good eggs, she'd ovulate 20 of them.
Oh my God.
And so she was either nothing or everything. There was actually nothing in between. So we'd back off the medication, try again, no ovulation, and then we'd give a little bit more, 20 eggs. And we go, okay, can't let you get pregnant with 20 eggs, right? That would just be terrible. I'd lose my license for sure. So we'd then back it off. And we did this a couple of times, and she got frustrated, and she says, let's just do IVF, not for the sake that I need it to ovulate, but I needed to control the number of eggs that get released and see sperm. So we often use that as a way to say, you're going to make a lot of eggs. Let's make them all. But then let's control the number of eggs that are going to see sperm and only put 1 back in.
Yeah.
Instead of what happens to most women with PCOS is they end up with multiples. And we know, Duncan knows this from the days that he was doing OB, multiple are basically have potential problems. They may not survive. They may have complications. They're going to have preterm issues. They can have higher order multiples, more than 2. And that can be real big problems. And those are things that we can actually prevent.
Yeah,
that's
and again,
good. Getting back to that prevention part.
Well, what do you think? Okay, now you're saying it is a hereditary condition?
Yes. Actually,
why it seems like it's more prevalent than ever before. Is that because it went undiagnosed?
No. Great observation. Fantastic observation. Why is PCOS more prevalent than before? 1, society. Remember, there's a ovarian metabolic problem. If you make the metabolic problem worse, you're going to get more PCOS. You're going to get these borderline people that actually are.
So it's diet?
There you go.
Okay.
So if you become a little bit overweight, the PCOS might show up that it didn't show up before.
Okay.
And so if you look over the last 100 years,
Yeah.
It's way more, it's way easier.
Processed food. It's processed food.
Well, I mean, just carbohydrates. It's so cheap to get something that kind of gets your metabolism out of whack. And that's the problem they have. They have the inability to process glucose properly, which glucose is the sugar, the basic sugar of carbohydrates. And so when they have more carbohydrates, they induce a problem in the ovary. And remember, a woman's body wants to get pregnant when things are good. They do not want to get pregnant when things are bad. I often make this illustration. Duncan and I probably remember as residents, we used to work in the hospital, and we'd have the ICU call us, ICU, intensive care unit, the worst of the worst people that were really in bad shape. And we'd get a call from the ICU, and one of the ICU doctors would say, "We got a problem, somebody's menstruating." Right? You don't get a call from the ICU unless the woman's menstruating, because the doctors don't know what to do about it. And the first question we'd ask is the patient getting better? And they go, "Yeah, we just extubated her 2 days ago." I go, "There you go. That's why she's menstruating." Women in the ICU don't menstruate. They got more important things to worry about than having a baby. So when things are bad, when you have what we call stressors, stressors can be a lot of different things, you have the inability to become pregnant. And so all of these things are things that are preventing women. You want to get pregnant when times are ripe, not when times are bad.
How can that genetic change be diagnosed? I mean, it can.
So one of the things that we see is if you look at a headache, the analogy of that, it's really hard to diagnose it, right? You kind of make assumptions. And it's the same thing for PCOS. We've had committees over the years say, we have this big committee, we get a bunch of doctors in a room to try to agree on the definition of PCOS. And if you look over the years, those committees have gotten to the point where they say anybody can have PCOS because the symptoms are so vague. You can have infertility, you can have regular periods, irregular periods, and you have to have some type of what we call androgen excess, some type of either elevated testosterone or hair growth or something that's there. That's it. And I can tell you, you can put that label on a lot of people, but do they actually have the problem underlying that? That's the thing that you have to do. When we look at I was hoping you're going to ask me that question on genetics, because the way men pass it on, we look at the women that have it and we ask them about their fathers. Did they have early male pattern baldness? That's the male sign for PCOS. Androgen excess, lose your hair. And so, I'd look over at Duncan and I'd say, "Hey, you know what? You may be a carrier for PCOS."
Yeah.
And so you might say, "Well, Duncan's a thin guy." I go, "Well, that could be even really bad because the thin people actually have the worst metabolic problems." And people go, "It doesn't really make sense." So I always like to do this. I like to say, "Well, prove it in a way." And I go, "Okay." Duncan and I also know about women that get pregnant and women that have gestational diabetes, meaning have glucose problems in pregnancy. I'm going to ask Duncan a question here. What do gestational diabetic babies, are they big or small?
They're big.
They're big. Okay. Now, let's ask the other question. If the woman was diabetic before she got pregnant, what are the babies?
If she was diabetic before she got
pregnant,
they can be very small because they have intrauterine growth retardation.
Who's got the worst problem?
That one.
It's the small ones. So when you have just a little bit more glucose, you inflate the system. When you have too much glucose, you kill the cells. And so babies, when they have too much glucose, they become what we call IUGR, intrauterine growth restriction, really tiny. But if they have diabetes after they start growing, they just have big babies. And so that's the same thing that's kind of happening here. If you're thin, you're more likely to have that type of glucose problem, like the woman who has diabetes before she gets pregnant. So you can look at, the thing about medicine is connecting the dots. It's connecting all these things that we have in our head and going through it and using them to be able to kind of look at physiology and kind of piece it all together. And it's there. It's a great puzzle. You kind of figure it out.
I know. And you do. And I really respect that about you and Duncan. Because it's so evident when I was listening to you guys talk the other day about my niece. And you guys got really like geeky, medically.
Yeah.
And I'm like...
I told him that was the most fun I had all week. He goes, me too. And I thought, we're big doors. The thing is that, somebody said to me, well, you're really smart. And I go, I feel really dumb. I feel like I don't know anything. But, it's the old adage, the more you know, the less intelligent you are. Mm-hmm. The part is never to think yourself that you have all the answers and to be always open for the possibilities that are out there. Some patient is going to come to me and teach me something by what she says, what she does. And I have to be open to that experience. And so when patients come to me, again, I'm there, I impart a lot of knowledge. I have 22 years of experience. I have more research than probably 98% of the infertility doctors out there. And a lot of people don't think, specifically doctors. This is the great thing with working with Duncan is he has the ability to think and never says, oh, that can't happen or this. We're always open to the possibilities. And it's our joy to expand our understanding and not to restrict it. I think that's what makes an incredible doctor, is one who knows their ignorance and is willing to learn.
Got to learn.
You got to learn all the time.
Yeah.
You said that the gene has been recognized, though. Can you find it in the blood test? Is there a genome? We don't know what the gene is. Okay.
Because it's probably multifactorial in its ability. That becomes hard.
Yeah.
People often ask, why can't you just pinpoint it? And I tell people, well, I used to do a lot of research in delivery and how women go into labor. And the interesting thing is when you use models, you knock out a gene and they deliver fine. And then you knock out another gene and they deliver fine. And you go, well, what's the problem? This is a gene we thought was there. And it is. It is one of the genes. Like early on, we give people PIT for deliver. It can make them contract, right?
Yeah.
So oxytocin, which is the hormone that your body gives, Pitocin is the one we give, and every hospital gives it. And if you block the Pitocin receptor, guess what? They still contract and deliver. Mm-hmm. And so what you have to understand is really important things in the body have multiple redundancies. Mm-hmm. And when you take one and you destroy one, the other one just picks up and it works without you even missing a beat. So we know it's there because we can see it in families. We can trace the history behind it. But if you ask us, what is the gene that's there? We don't know yet. And that's the mystery.
It is.
What about, going back to PCOS patients, harvesting those eggs?
Yeah.
I mean, it seems to me like a good idea because PCOS isn't really going to go away until the patient either becomes infertile.
Right. We call it, when I teach residents, we call PCOS, there's 2 P's of PCOS. And it's either you're getting pregnant or you're on the pill or the oral contraceptive pill to control it. And when we give the pill, it's there to tamp down the symptomatology. And you have to give a high enough dosage pill for the suppression to occur. Often people are on the lowest dose pills and it doesn't work. And that's where you get these breakthrough pregnancies and such.
And symptoms.
Yeah, exactly. Because you got to really, these people are they're churning out things and you got to squash it. And it's really hard to do that when they have a lot of excess. But I'll give you an example. We had one lady that got diagnosed with PCOS in town. And we said, I gave her the whole spiel of saying, hey, you could go through and we could try this. And she says, well, I want to have a big family. I said, okay. And she ended up opting to go to doing the IVF. Mm-hmm. And we got a lot of eggs and we made a lot of embryos and we tested them, which ones are genetically normal or not. And I just sent her off for her 4th pregnancy. She's had 3 kids already on the same IVF cycle. Mm-hmm. And I just signed her off to her OB with her 4th child. Wow. 1 IVF cycle, 4 kids.
Yeah.
That's the power. And what she got with that was she didn't have to go through all the rigmarole of trying to ovulate, do the right thing with that. None of them were multiples.
Yeah.
Mm-hmm.
They were all genetically tested normal. She didn't have to worry about Down syndrome, Turner's, any type of those.
That's the beauty of assisted reproductive technology. It's just
preventative.
Avoiding. It's preventative.
Yeah, it's preventative. And what I have a couple questions that I want to ask.
Just a couple.
Hold on.
Oh, wait.
Okay, I want to.
Okay,
right,
so we have 3. All right, so the cost of egg freezing
mm-hmm.
for just an average 26, 27, 28-year-old.
Now, Lori's going to look at me and go, oh my God, I can't believe you're going to say this. But it's about $9,000.
Okay.
And don't quote me an exact price, but it's somewhere around $9,000.
Okay. So as time goes on, and which kind of leads into my second question, because of how far we've come in the last 20 years, where do you see all this 20 years from now?
Oh.
Take a stab. What do you think?
Oh my God. I think, first of all, we genetically test our embryos now. We do almost all of the embryos that I transfer are genetically tested, mm-hmm. which is phenomenal in that we're eliminating. None of my patients are going to have Down syndrome babies.
Mm-hmm. Right.
None of them are going to have genetic abnormalities of chromosomal rearrangement problems. Mm-hmm. So I've just eliminated all of that. As a healthcare thing, that is tremendous. As an impact in society, that's huge.
Yeah.
Now, what's going to happen in 20 years? We can genetically test an embryo for every gene in the system. We can do full genetic testing. Right now, it's expensive, but we do have patients that do it with us. Means they can look at every gene in there. Mm-hmm. And you can then select what you want to put back in or not. The real thing that's going to happen is we're going to do gene replacement. We're going to, if you think of the ultimate preventative medicine, now this is where the hair on my arms are going to jump up.
Yeah, I just got really excited.
Yeah,
too.
I do too. You could see it right there. I get goosebumps when I talk about it. But you could say, let's eliminate anybody in the world from having diabetes. Let's take all the embryos that have that diabetic defect in their gene and just fix it. Mm-hmm. Now, people are doing this. They're doing gene replacement in people that have diabetes and are trying to replace a gene. And they're actually doing it successfully. But they've got to change so many cells. Think about it in a petri dish. When I have 100 cells, changing 100 is a heck of a lot easier than changing all the cells in the body that are going to make those enzymes. So fixing problems is going to occur. I think it's going to happen within the next decade. But in 20 years, the kids that are born are going to look at the other kids on the playground and said, did your parents not love you because you weren't genetically fixed? Because they're going to say, why didn't they do that? Because you can eliminate disease. Can you imagine eliminating disease from the population? That's an incredible thing.
How do you do that? Sorry, I have no idea what you're talking about.
Yeah, so
what happens there?
Under the radar, I'm going to say it's about 15 years ago, there was a Nobel Prize given for something called CRISPR. And CRISPR is a technique of replacing genes. Now, on the face of that, we've been replacing genes for ages. We do that. There's not a fruit you eat that's not genetically modified. GMOs, right? Mm-hmm. And it's modified to make crops better. We do this so that people in Africa can make crops so that they can eat because the environment has changed. We as humans change the environment. You got to change the crops. Can't wait for the crops to change themselves. So we advance that process. And CRISPR, how we used to change the genes is we had to change the genes in an environment that heated up the DNA or denatured the DNA, fuse it, and then come back. And so it's not a process for living tissue. CRISPR is a technique of changing a gene at room temperature. So you can actually, on the tabletop here, you can take a set of DNA and you can take and look at the gene you're trying to replace, and you can actually just do it at room temperature and fix the gene. That's why we can use it in humans.
But what are you putting it, like, how are you replacing it?
You put it with whatever DNA you want to put inside. So if you say something like diabetes, and diabetes, the gene.
So you identify the gene.
You code for that insulin deficiency, and you cut out that gene and replace it with the proper one. You just fix it.
And where do you get the proper one?
You make it.
Okay, so it's just made.
Yeah, it's.
Is it man-made?
Yeah,
like a man-made.
Well, I think about this. DNA is just base pairs. Okay, when I used to edit genes, meaning we'd put genes. How about this? Most drugs are made by bacteria. The bacteria doesn't normally make it, but what we do is we say, "Hey, I want you bacteria to make the drug for me." So you made it in a vat. So what you do is you insert the gene in there. How do you make it? It's pretty easy. What you do, like at University of Chicago, I used to go down there, fill out a sheet and say, I want you to make me this series of base pairs. And I'd put the order in, and the next day they'd give me a vial with those base pairs in it, and I would just basically put it in. Now you can do that at room temperature to the point where you can replace any gene.
So 20 years from now, some of the kids on the playground will have been created
GMO.
They'll be GMO. They'll be genetically fixed. Their defects will be fixed. Would you everybody says this, when they want to get pregnant, they want to have a baby. Really inherently what they're saying is they want to have a healthy baby.
Mm-hmm.
Mm-hmm.
Nobody says, yeah, I don't care if I just get pregnant. I just want to get pregnant. They will say, I want to get pregnant. I want to have a healthy baby. We want the best for our kids. If you told me for all the kids that have cancer, I could prevent them from ever having cancer, would you do it?
Yeah.
Okay. If I said, hey, you know what? I could prevent your kid from dying of a heart attack at 35, would you do it?
Yeah.
Okay. So you can go along this and we can keep going to the point where you feel uncomfortable, right? So now I can say, hey, you have blue eyes in your family. What if I gave you all your kids brown eyes?
Okay, but how much is this going to cost? And this is longevity. This is the answer to longevity medicine.
This is medicine 3.0 in reproductive endocrinology.
Well,
Yeah.
It's actually, I'll give it a step further. It's the elimination of medicine.
Which is basically what we're talking about. Yeah, it is actually. It's going a further step.
Yeah,
because
it's trying to put everybody out of business.
Right. And then you've got...
Okay, but how much would this be?
Well,
Go ahead, ask your question.
Anything, that's like asking a question. We went out one day and to buy our daughter TV for her first house, and she wanted a big plasma TV, and I think it was like $800. And I told her, I go, the first big TV I bought was like $5,000, and I couldn't afford it, so I never bought it. So if you ask in the beginning, it's expensive.
Right. Yeah.
Yeah.
Like, I'll give you this. We can do an entire genome on an embryo. And they even have a panel for autism. You're going to ask me, how much does that cost? The full panel is $50,000.
Mm-hmm.
Wow.
But some people are willing to pay that.
Some people are willing to pay that. If you look at it, what you can prevent, it actually might be worth it.
Mm-hmm.
But if you ask me how much that's going to cost in 10 years, it'll probably be $1,000. It might be $500.
And the problem then becomes just so much specialization that you're actually making the GMO is really now nobody wants to have a kid under 6'6".
Yeah,
and they also want the cardiovascular genes or the improved performance genes that can be added on and make your own team.
Right. It's going to be a challenge for society, but I will press on the fact that the only way a species advances is by evolution. This thing you may or may not believe in, but it's evolution. We started. And I'm going to go back because I'm going to tie it into something from the ovary thing. Evolution is that ability for genes that help the species prosper and genes that don't get eliminated. And I will submit that humans have somewhat eliminated
completely
natural selection.
Not somewhat.
I'm trying to be nice. But we've almost eliminated natural selection from our own species. And any species that doesn't have that ability usually dies out. I think this is the way we reintroduce that to the species to make it better. Now, you're going to say it's not the environment making the decisions, it's humans making the decisions. The environment's fallible too, and we are such. And so what are we going to do with it? That's going to be the challenge. What are we going to take? What are we going to eliminate? Right now, I have the ability to do it today, but nobody in the world will let anybody do it. Some people have tried in China, and it's there to the point where, again, nobody's really doing it in an active form. But let me go back to, we're talking about evolution. We all have these evolutionary remnants within our system. When a baby is growing in utero, we all have tails. Everybody in the room had a tail. Congrats. I don't know if you knew that. We all had gills. And we all developed, and we went through our evolutionary thing. I had one person ask me, when we ovulate an egg, why don't we just grow one egg? Why do we make a whole bunch? And I go, that's a great question, but here's the answer. See, we evolved from other species that have litters, dogs, cats, mice, and rats. And they allow all of them to ovulate. In your house, if you have a rat, there's this thing, and I won't get it right, but for as long as you live, your rat will go through 80 generations. Okay. You'll go through one, and it'll go through 80 generations. Yeah. Because it'll make litters and go through. And we retain the ability to make litters. But our body has evolved so that we only ovulate one. We're really, really good at it. Because I ask everybody in the room, anybody a twin? No, everybody's shaking their heads. You're a twin. So you're one of the few. Your mom had a bunch of these eggs. And instead of ovulating one, she ovulated two. Okay? Now, when do twins most likely occur? They most likely occur in older women. So how old was your mom when she had you?
28.
Okay. So that would be unusual. Most of the twins are actually in the 40s. We'll notice that. But what ends up happening is that you have a bunch of these eggs, one ovulates, and you throw the rest away. It's a lot of waste. Why would you build a system like that? Well, I always tell people the human body is not like we build the system just for the humans. We have all this genetic code that just keeps getting added to. And so we as infertility doctors, all we do is de-evolve you. We make you have litters.
Yeah.
And we can control what happens.
Well, okay. To an extent, we can control.
Yeah.
So here's one of the problems. You harvest the eggs, you fertilize them. They're all great. You take one of them and implant it, and everything's good.
Yep.
And then you've got the other 19 in deep freeze in Alabama.
Yep.
All with individual rights.
Whole different story. But let's go back to your statement. So not every egg becomes an embryo. And not every embryo is genetically normal.
No, okay.
Let's take your 30-year-old. To get one genetically normal embryo, we need 3 eggs to make one embryo.
Mm-hmm.
And for every embryo, half of them are normal.
Right.
It means you need 6 eggs to make one normal one.
Mm-hmm.
If you're 35, you'd need 9. And if you're 40, you need a whole bunch. So this idea of embryo excess doesn't exist a lot. We normally have a struggle finding it. But you're right. Now you've got embryos in the freezer. And the question becomes is, what are you giving rights to? That's a really loaded question. And I used to practice in Arizona. I fought in the Senate and the House of Representatives for their laws before they were passed against them, because most of what we make is going to be abnormal and is never going to survive. And we're giving rights to things that can't survive, that were never meant to survive. That's the first problem. Then we're dealing with issues of what do we do with these embryos that have the potential but can't get anywhere until somebody hosts them. And that's a complicated question.
Yeah, but I mean, the only reason I bring it up is because of the recent ruling in Alabama that these embryos have rights.
Yeah, and it makes
it... But it's ridiculous.
Yeah. Well, it does a couple of things. At first, you can't practice medicine because what I found funny is the Attorney General said, we won't prosecute anybody, any of the doctors. Not that they can't prosecute any doctors.
They decide at this point.
They'll decide not to, which means that as an infertility doctor, if something happened, you could be held liable for manslaughter. Wow. So would an infertility clinic want to do any business here? That's why they all shut down.
Yeah.
Legally, they couldn't.
It's ridiculous.
There's no ability for them to work. And I think, there's this huge pressure across the United States to eliminate women's rights. And it is really, really something that we're going to have to understand a little bit better. And part of that is we're going to have to start educating people about what we're talking about. Because it's untenable right now. It really is. You're holding people hostage to do things. And we just don't do that for men. I find it funny that almost every insurance plan pays for Viagra, but they don't pay for the birth control pill. That makes no sense to me.
Right.
It's horrible.
So our next series will be on how we fix this.
Excellent. Excellent.
Dr. Dan.
So let me say, hey, I wanted to talk about, we're going to have a
that's right,
patient seminar. Yes, an Empower patient seminar, May 21st. It's going to be called Infertility 101. You can ask me questions. I'm going to give information about basic fertility. It's going to be at 6:00, and you can call our office anytime if you want to be there. It's 805-455-6500, and answer all your fertility questions, because that's what we're about.
Is it at the office?
Yes.
Okay, what date again?
May 21st.
May 21st.
At 6 p.m.
At 6 p.m.
Thanks. Been great. Wonderful.
Thank you.
Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcast, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.